Hi, I'm Stephanie Chandler. I am one of the pediatric electrophysiologists at Ann and Robert H. Lurie Children's Hospital of Chicago, and I'm going to talk to you guys today about arrhythmias in the NICU. The learning objectives for this talk are outlined here. We'll talk about normal and abnormal ECG parameters in newborns. We'll talk about bradycardias or bradyarrhythmias. We'll talk about narrow complex tachycardia, wide complex tachycardia. And in doing all of these things, we'll review normal and abnormal ECG parameters, we'll identify the most common types of bradycardia, and we'll understand the differential diagnosis and treatment of narrow and wide complex tachycardias. So it's a big ask, but hopefully we'll be able to get through it. Before we start, I like to just review the normal anatomy and conduction of the heart. You all know this, but electricity begins in the heart of the sinoatrial node, and that impulse spreads, creating the P wave on the electrocardiogram through both atria. It reaches the AV node, which is, as far as we understand it, a right atrial structure, and then that impulse is transmitted into the His bundle and through the Purkinje system. And then following depolarization of the ventricle, then there's repolarization of the ventricular myocardium. Let's review some electrocardiograms. So why does the 12 lead matter? The 12 lead electrocardiogram is the cornerstone for how we as heart rhythm specialists evaluate heart rhythms. We like them both as a baseline and also when people are in tachycardia because it allows us to compare a lot of different things. You all look at a fair few ECGs on newborns and neonates, so you're going to feel fairly comfortable evaluating the average 12 lead on a newborn. But just sort of as a review, when we think about each part of the electrocardiogram, we think about the P wave as atrial depolarization. We think about the PR interval as conduction through the AV node. We think about the QRS as ventricular depolarization, and we think about the T wave as ventricular repolarization. And as an electrophysiologist, we assess each part of the electrocardiogram, each morphology, to try to help us understand what somebody's baseline looks like, and then how do we use that baseline to compare it to any active tachycardias or bradycardias and assess what we think the rhythm is. When we talk about the normal newborn ECG, this is just a 2-day-old healthy baby. The heart rate can be anywhere from 100 to 180. Newborns tend to have shorter PR intervals than adults. The classic teaching is that an average PR interval for an adult is 120 milliseconds. For a newborn, it's going to be much shorter than that. 80 is pretty common. QRSs are extremely narrow. Ventricular depolarization is very quick in newborns, and so your QRS is going to be really, really slim. Right axis deviation is exceedingly normal finding in the newborn period because, as we know, fetal physiology, or in fetal physiology, the right ventricle is the active and dominant ventricle. And so it makes sense then that when a baby is first born, when you look at their ventricular depolarization, their right ventricular forces are going to be stronger than their left ventricular forces. So a newborn usually has right axis deviation. About 125 is usually the average. But it can be up to 180 degrees. And then this axis changes as newborns age through. So at around a month of life, you expect a QRS axis of about 90 degrees. And then when kids are around 3, then they're really in the inferior axis realm and they should be around 60. QRS voltages in the normal newborn ECG are small in the limb leads. I love this book. It's by Park, and it's called How to Read Pediatric ECGs. And it goes through step by step different ages of normal newborn to 1 month to 6 month olds. How do you read ECGs, and what do you expect to see in each of the leads, the limb leads, and the precordial leads. And so what you expect in the normal newborn ECG is that the QRS voltages in the limb leads are going to be small. That's pretty normal. Like we said, you should have right axis deviation. And your precordial R waves, which remember your precordial leads are your V1 through your V6, these should show a right ventricular dominance. And that means you're going to have tall R waves in V1 and V2 and deep S waves in V5 and V6. Your T waves are often pretty small in your babies. And your T wave may be upright in V1 on day of life 1, but it should become negative by day of life 3. We think it's pretty normal for T waves to be inverted in the early precordial leads, V1, V2, V3, in sort of the newborn and early childhood years. If we see a teenager with inversion of their mid-precordial T waves, we think that's abnormal. This is a nice ECG of a 4-month-old, and what you can see here is the axis has started to move leftward. So your RV forces are less, your mid-precordial forces are coming out. The frontal plane axis moves leftward. The R waves in V1 through V3 become more normal. The Q waves in the inferior leads and the lateral leads are much smaller. And the heart rate, which is probably the most apparent thing on ECGs, just becomes slower. So day of life 1 baby's heart rate and a 4-month-old's heart rate are not going to be as different as a day of life 1 baby and a 16-year-old, but you're still looking at a change over time as kids age. And then the other thing to know is that the T waves will change. So here's a very normal T wave pattern for a 4-month-old. We expect T wave inversions through the early precordium to mid precordium, and then they go positive out here in the lateral precordial leads. That's a very normal pattern. By the time you get to be between 1 and 6 months of age, like we talked about, your QRS axis is going to go from right to more inferior. And by the time you're 6 months old, your QRS axis is going to be usually less than 90 degrees. Your R wave continues to be a little bit dominant in V1, but should get smaller. Like it shouldn't be as huge as it was. Your T wave in V1 can remain negative and even in your early precordial leads. And many ECGs have strong precordial forces, meaning big R waves and big S waves in what we call the mid-precordium. And that can look like biventricular hypertrophy on ECG, but as we know, ECG screening for ventricular hypertrophy in infants is not the best tool. So if you see someone who persistently has huge precordial forces in their mid-precordium, then it's reasonable to get an echo on those patients, but it is not uncommon in those small babies who don't have a lot of fat, who have a small chest wall and their heart lies right underneath their sternum, that their mid-precordial forces are pretty strong. I'm going to give one last spiel on neonatal QTCs. We get a lot of consults for neonatal QTCs, and there are real reasons to consult us. And then there are sort of the normal physiology of the newborn period. So we know that if you did ECGs on 100 babies on day of life 0, a majority of them would have a long QTC, meaning it could even be over 500 milliseconds. And that is partially because of maternal hormones are still circulating through babies. And so if you ever see our reads on day of life 0 ECGs, if the QTC is long, we will often say repeat in a couple of days, because for the majority of patients, that QTC will normalize over time. But if you see a long QT interval, specifically over 500 in a day of life 0 or 1 or 2 infant, it's worth just checking for a family history and making sure that there's no family history of long QT syndrome, repeating in the following days. And if that ECG in the following or subsequent days is still abnormal, then they can follow up in cardiology in 2 to 4 weeks, depending on your clinical concern. And we, as electrophysiologists, are always happy to lay our eyes on those ECGs and help you talk through those questions. But a lot of babies who have abnormal ECGs on day of life 0, by day of life 2 or 3, the QTC will look fairly normal. I put up this slide just to highlight what a really abnormal ECG would look like in a baby that does have long QT syndrome. This is actually a patient of mine who has long QT2 and whose mom also has long QT syndrome. And this baby, this is actually day of life 0 ECG. And I think there's 2 really striking things about this ECG when you look at it. The first is that this is a day of life 0 baby, and this heart rate is really slow for a baby that's that young. This is quite profound bradycardia, and we see that a lot with long QT syndrome. So when you see the combination of bradycardia and a QTC that's very long, in addition to, if you look at this T-wave morphology, specifically out in this lateral precordium, these just look abnormal to your eyes. And when you see this plus bradycardia plus a long QT, then it's worth really sort of thinking about, could there be a family history? Could this actually be real long QT syndrome? And how do I follow that up? We'll move on now to talking about arrhythmias in the neonate, and we'll start with bradycardia. I'm going to take a second to review, sort of as a global spiel, sort of common mechanisms and types of neonatal arrhythmias. So there's ectopy. When we talk about ectopy, we think about premature atrial contractions or premature ventricular contractions. When we talk about reentrant tachycardias, we're thinking about SVT or atrial flutter. When we talk about automatic tachycardias, we're thinking about our jets, our ectopic atrial tachycardias, and our accelerated ventricular arrhythmias. And the reason this matters is something reentrant versus automatic is it speaks all to management of those arrhythmias. And I'll get to that a little bit later. But when you can put arrhythmias into buckets, it helps with management. And it helps with understanding mechanistically how things are happening and why they're happening. Bradycardias are we're going to talk about AV block. And then we also already mentioned that in long QT syndrome, you can also have bradycardia. And then in inherited arrhythmias, we'll talk a little bit about long QT syndrome in general. Like I said, when we talk about mechanisms of tachycardia, the reason this really matters is there's reentry mechanisms, which are things that are of a regular rate. They're paroxysmal. They're really fast starting, really fast stopping. We can initiate them quite easily when we're pacing kids. And then importantly, these are the arrhythmias that you can cardiovert successfully or rapid atrial pace or transesophageal pace, which we'll sometimes do as an EP group. Automatic tachycardias are different. These are tachycardias that they have a wide variation in rate. They have sort of a warm up and a cool down period. They don't just go from 0 to 270. They go from 160 to 170 to 180 to 190 and then come back down. They tend to be initiated by stress or fever or catecholamines in the newborn period. And then these are refractory to medical treatment. So if you try to cardiovert EAT, you're not going to be successful. You need medication to do those things. And so those are the things that we talk about. Triggered mechanisms, I've put a big heart over because those are really a purely electrophysiologic principle that you're not going to have to worry too much from a clinical perspective about. But SVT, that is reentry, those atrial flutters and SVTs, those you can cardiovert and successfully terminate. Automatic tachycardias are going to need medication. I bring up this telemetry because if you meet any electrophysiologist, you will probably meet us first sitting at telemetry. Telemetry gives us a huge amount of information. It's like the equivalent of ECGs for us in some ways. It's sort of our bread and butter of how we review things. So when we look at telemetry over time, this trend that we see here in panel A is much more consistent with an automatic tachycardia. This could be sinus tachycardia, it could be EAT, but this sort of slow up and down, this undulating hill looking like thing is much more consistent with an automatic tachycardia. These sort of panel B, these sort of fast on, fast off, upright, sort of big changes in heart rates that sort of plateau. This is much more consistent with SVT, much more consistent with reentrant mechanisms that you could cardiovert or defibrillate out of. And so this is just important because this is another tool that you can use in your armamentarium to help understand what the mechanism of your arrhythmia is if you have one. So we'll go back to bradycardia here. When we think about bradycardia, sinus bradycardia is pretty common. We see it secondary to cardiac disease. We see it secondary to respiratory disease. We see it a lot when babies are pooping with enhanced vagal tone. And we hopefully don't often see this, but we can sometimes see it with increased intracranial pressure. From a cardiac perspective, the thing that we want to sort of highlight just for this talk, because the kids with structural heart disease sort of are going to be on our radar anyway are the kids with long QT syndrome. So these are patients that can present with pretty profound sinus bradycardia, or if it's really severe, can present with 2-to-1 AV block. Like we talked about, the normal newborn heart rate can be anywhere from 90 to 180, and the lower limit of this range is probably higher for your preterm neonates in your NICU. But these are just sort of important things to keep in mind. When we think about bradycardia as it relates to AV block, you all know this, but just as a review, first degree AV block is when your PR interval, you have a 1-to-1 relationship between your A's and your V's, but you have a long PR interval. Secondary AV block, you have a progressively prolonging PR interval followed by a P wave, not followed by a QRS. This is known as Wenckebach phenomenon. This is a pretty normal phenomenon, for example, for teenagers who sleep at night. We see a lot of Wenckebach on Holters. Second degree AV block type 2 or Mobitz type 2, these are non-progressive PR prolongation, so stable PR interval followed by a non-conducted P wave. And secondary AV block type 2 suggests that you have some form of His-Purkinje disease, probably. So disease below the level of your AV node within your His-Purkinje system. 2-to-1 block, it sort of is also considered second degree, so 2 P waves for every QRS. And then third degree AV block or complete heart block is a complete dissociation between your atrial rate and your ventricular rate. We talked about this a little bit, but long QT syndrome is characterized by sinus bradycardia and then abnormal T wave morphology and a QTC that's sort of in the newborn period, sort of anything over 440 we would consider abnormal. But oftentimes in these early babies, we'll see QTCs as high as 480 to over 500. Long QT syndrome in severe cases can present with 2-to-1 AV block, and so this would be a pretty abnormal phenomenon, but would be something you would definitely want to get a cardiologist or electrophysiologist involved in. What you can see here is 2 P waves for every QRS with pretty profound bradycardia and pretty abnormal. This is actually the P wave hiding in here, but you can see that this T wave is pretty long and pretty abnormal in appearance. This is going to be a very, very rare occurrence. I think in my entire tenure in EP, I've only seen this sort of a handful of times in babies. Congenital complete heart block is probably the most common form of heart block in the newborn period. And as you all know, these are babies that are often born to mothers with maternal Rho and La antibodies, so SSA, SSB antibodies. And then they have congenital complete heart block, often in utero and then in the fetal and sort of the post-utero period. These are babies that are often known about before they're born because the heart rate is detected, the abnormal heart rate is detected during prenatal screening. And so we've often done a number of things to sort of evaluate these babies even prior to birth. And then our goal post-natally is to assess, is their ventricular rate going to be enough from a cardiac output perspective for them to do the normal activities of babyhood for a period of time, or are they someone that's going to need an early pacemaker? And that's sort of up to us to consider. But this is complete heart block, as you can see here. Your A's are marching out, your V's, you have a narrow ventricular escape, and then you have some wider ventricular escapes here. But this is what congenital complete heart block looks like on ECG. So we'll move on to talking about tachycardia now. What I try to teach people in general when I start talking about tachycardia is it can be very humbling and a little bit daunting to try to name an arrhythmia the moment you see it. I often, even as an electrophysiologist, can't tell you with certainty the moment I see something what it is. It takes me some time to figure it out. So what I teach people when they're thinking about how to talk about arrhythmias, because so much of cardiology and electrophysiology is about the lexicon that we use, is how to describe arrhythmias, because pictures are really worth 1,000 words when it comes to heart rhythm sort of assessment and management. And so when I think about describing arrhythmias, I think about 4 major facets. I think about, is it fast or slow, knowing that this is age dependent? Is it wide or narrow? And when we talk about wide or narrow, we're talking about what does the QRS morphology look like? Is it regular or irregular? Meaning, is the QRS coming at a very regular interval, or is it coming at an irregular interval? And then the last thing I have people do is look at the P waves. What do you think the relationship is between the A's and the V's? And this can seem really daunting when someone is going 270 beats a minute, but the more you use this mental framework to think about and talk about arrhythmias, the easier it's going to be for you to communicate with cardiologists and electrophysiologists, and also the easier it's going to be for you to name these arrhythmias really quickly. So we know fast and slow is a relative term. So a rate of 300 beats a minute for a 1-day-old baby girl is fast. That would be fast for anyone. But for a 16-year-old, a rate of 150 for a 1-day-old wouldn't be that fast, but a rate of 150 for a 16-year-old is quite fast. So when we talk about is it fast or slow, we take that in the setting of how old is this patient, obviously. When we talk about QRS is something wide or narrow, we're talking about what does this QRS actually look like? And so here's an example of narrow QRS morphology. Here's an example of wide QRS morphology. We could get into the nitty-gritty details of usual complex tachycardias, but that's really a cardiology-specific conversation. And so for the purposes of this talk, we're going to keep it as we're either wide or we're narrow. And are we regular or irregular? So when we march out our QRS morphology, our QRS timing, does this look like it's marching out at a really regular set interval, or is this pretty irregular and ratty like seen down here? So we'll talk about ectopy for a second, and then we'll delve back into those tachycardias because everything starts really with ectopy. So PACs are the thing that you all are probably most familiar with. This is such a common phenomenon in the newborn period and in the NICU. You can have normal premature atrial contraction, so normal sinus beat, abnormal beat with an abnormal P wave morphology. You can have aberrantly conducted PACs, so a wide QRS following an abnormal P wave, and then you can have blocked PACs. So normal beat, ectopic beat that is not conducted because it's coming so early that the His-Purkinje system is still refractory. So these are things that you're going to see very commonly in the newborn and NICU period. Premature ventricular contractions are less common in the newborn period, but still do happen. We sometimes refer them as ventricular ectopy or PVCs. They are wide, complex beats that come relative to the sinus rate at an abnormal interval. And they're often pretty easy to identify. They're wide, there's no P wave before them, and they just look very different. So these are usually pretty easy for people to identify. These are PVCs in a pattern of bigeminy. So it's not uncommon for newborns and babies in the NICU to have some PVCs. It's not that common for kids this age to have bigeminy or runs of non-sustained VT. So if you're seeing those types of things, that's definitely a reason to sort of give cardiology a call because we may want to do a little bit more evaluation. Whereas PACs are so ubiquitous. That can be atrial bigeminy, PACs, those types of things can be seen very frequently in the NICU and newborn period. We'll move on now to talk about narrow complex tachycardias. So from an EP perspective, my brain functions in sort of a pretty simple hierarchy. So when I think about types of tachycardia, I think about narrow to complex tachycardias, which are above the level of the AV node, or I think about wide complex tachycardias that are below the level of the AV node. Narrow complex tachycardias, the things that you're going to be familiar with are atrial tachycardias and forms of SVT. Junctional tachycardias are often very, very narrow as well. Those are much less common in the non-post-operative surgical phenomenon. So if you are taking care of post-op congenital heart patients, then yes, jet and junctional tachycardia are going to be something that you're going to be seeing. If you are taking care of kids who have never had cardiac surgery, then junctional tachycardia is just not that common. Wide complex tachycardias are going to be ventricular until they're proven otherwise. You will always be safe to assume that a wide complex tachycardia is ventricular tachycardia and to treat it as such, and we'll walk through that a little bit. SVT is the most common arrhythmia in the normal newborn period, or tachycardia in the normal newborn period outside of sinus tachycardia. It is extremely common in the newborn period. It's common in the NICU. Going back to that original lexicon of how we talk about heart rhythm disturbance, with respect to tachycardia, you have a narrow complex tachycardia that is regular. And when you think about it's fast, and when you think about the relationship of the A's to the B's, it's really hard to see where there's P waves here. You might be able to convince yourself that there's a retrograde P wave coming through here. But either way, this sort of morphologic appearance looks pretty consistent with SVT. I do not expect you to remember or to commit this chart to memory. It is mostly a manifestation of that lexicon that we were talking about for discussion around tachycardias. So when electrophysiologists think about tachycardias, we think about what's the QRS width, is it narrow or wide, what's the relationship of the A's to the V's, and then is it regular or is it irregular, and then how do we sort of assess those things. This is, again, this is not something that I expect you to memorize in any way. This is mostly so that you understand that when we talk about these things, even amongst ourselves, we use the same language that we're teaching you. So just to see it again, because this is the thing you guys are going to see the most, narrow complex, regular tachycardia that is fast, 300 beats a minute, and likely 1-to-1 A to V ratio, making this most likely SVT. This ECG on first glance looks like the last ECG for SVT, but actually when you look a little bit closer, so again, narrow complex, very regular, but when you look here, this morphology of the P waves looks a little bit different than the last ECG. And so if you look at enough ECGs for babies, when you see this pattern, and it's really often most evident in the limb leads, this wavy morphology of a baseline with a very fixed regular QRS, this looks like atrial flutter. If you looked here, you couldn't tell whether this was atrial flutter or SVT, but if you look here, these P waves give you some subtle clue that there's actually flutter waves in there. And if you gave this patient adenosine, you would see that. Ectopic atrial tachycardia, narrow complex, can be regular. This is pretty regular, but can also be irregular. And it's not quite as fast as that SVT. But most importantly, when you look here, you almost could say to yourself, is this sinus? Because you see P waves before every QRS. But this is why a baseline ECG is so important, because you can compare actual P wave morphology in multiple leads at baseline to in tachycardia. And then what you would discover is that the P wave morphology looks quite different. And this is consistent with ectopic atrial tachycardia. Speaking again about management and telemetry. So automatic tachycardias like ectopic atrial tachycardia are going to have this sort of undulating appearance on telemetry. These are the tachycardias that you're not going to be able to cardiovert or terminate with adenosine. You're going to need medications, propranolol, other things to control these arrhythmias. Reentrant tachycardias like SVT and atrial flutter are going to look like this on telemetry, this fast on, fast off, and you're going to be able to terminate these with cardioversion. I'm only going to spend 2 seconds on this PALS algorithm because you all are very familiar with this, but this is mostly to say that in assessing patients, even PALS breaks it down into wide or narrow, and then what do you think is going on from there? Obviously, the most important thing from an inpatient perspective and from a clinical perspective is to assess what's the patient's status, how do they look? For those of you who've been taking care of newborns and NICU patients for a while, what you'll realize is that when a child is stable from a hemodynamic perspective globally, when they go into SVT, they're usually stable too. They usually don't care. Other forms of arrhythmia can look different, and so always making sure that you're assessing the patient's clinical status while you're trying to figure these things out is important. Lastly, when we talk about management of narrow complex tachycardia, there's termination of arrhythmia. So how do you abort an arrhythmia? And then how do you maintain long-term control? So termination of arrhythmia, you all know this, but SVT, you can terminate it usually with adenosine. Atrial flutter requires cardioversion, or if you have an EP on site, sometimes we can transesophageal pace. Atrial fibrillation requires cardioversion. Ectopic atrial tachycardia as an automatic tachycardia requires medication. So it's going to need a beta blocker or flecainide or procainamide or sotalol or IV amiodarone, and we are here to help you manage that. Long-term arrhythmia control is all about oral antiarrhythmics, and the choice of those is really usually a stepwise progression based on how serious the arrhythmia is and how sick the patient is. When we talk about wide complex tachycardias, we're going to talk about ventricular tachycardia. Again, wide complex tachycardias coming from below the level of the AV node, we want to assume that those are ventricular until proven otherwise. I bring this slide back only because when we talk about wide complex tachycardias, ventricular tachycardias always have more V's than A's. Their ventricular rate is always going to exceed the atrial rate, and that's a hallmark of ventricular tachycardia. Sustained ventricular tachycardia in the newborn period is not that common. What you will sometimes see is salvos, short salvos of ventricular tachycardia. So what you see here are wider complex beats that you don't see any relationship between V's and A's. Here's an A, here's an A, here's an A, but there's 5 V's here. And they often come in short salvos. So this is a pretty classic finding. If you're going to see ventricular tachycardia in the newborn period, this is what you tend to see, these short, quick salvos of monomorphic, non-sustained ventricular arrhythmia. Accelerated ventricular rhythm is actually a much more common finding in the newborn period. These patients are often asymptomatic. The rate of AVR is often about 10 to 15% above the sinus rate, and it's often self-terminating. We often see these short bursts over 24 hours, and they can start with fusion beats. There's still VA dissociation here, so there's more V's than A's if you can find those A's. But these kids often don't have any other cause for arrhythmia. Their electrolytes are normal, their blood gases are normal, their cardiac anatomy is normal. They don't have an intravenous line tickling their ventricle. They just have a slightly overactive ventricular myocardium, and we see this not uncommonly. I show this only because it basically pals when it says possible ventricular tachycardia, then it says expert consultation is recommended. You all deal with more neonatal AVR probably than we do. But if there's obviously any concern about a patient or there's a consideration of starting medication, always feel free to reach out to your cardiology team or your electrophysiology team. We are always happy to help and partner with you in the care and management of any of these patients. For most patients, the management of ventricular tachycardia, if it's hemodynamically compromising, so true VT, not just AVR, sometimes requires IV medication versus cardioversion if they're unstable. You can give lidocaine, you can give amiodarone, and then with the assistance of an electrophysiologist or cardiologist, we can help you with medications like procainamide, sotalol, or esmolol if those are indicated. Long-term rhythm control. For ventricular tachycardia, it's often a beta blocker, sometimes one of these other stronger therapies. But for accelerated ventricular rhythm or AVR, we often don't treat those kids. We just watch them and see what happens over time because we know that those focuses are going to burn out. This concludes the sort of iterative portion of this lecture series. If you have questions, I'll be doing the Q&A session with your group, and I'm happy to answer any questions either during that session or feel free to reach out to me by email anytime through Lori.